Welcome all to our ASBMR clinical workshop series organized on behalf of the ASBMR Early Stage Investigator Committee. The topic of today's webinar is Denosumab Discontinuation, and Professor Bente Langdahl, an international expert on this subject, together with her Ph.D. student Sophie Sølling, will discuss some of the problems that we may encounter around denosumab cessation, and in addition, practical advice pertaining the management of denosumab discontinuation, as stated at the recently published ECTS position paper, will be presented. Professor Bente Langdahl is internist endocrinologist and professor at Aarhus University and a consultant at the Department of Endocrinology and Internal Medicine at Aarhus University Hospital in Denmark. And she is a co-chair of the International Federation of Musculoskeletal Research Societies and past president of the ECTS. Professor Langdahl's main research interests are identification and investigation of genetic variants associated with an increased risk of osteoporotic fractures, osteogenesis imperfecta in adults, the impact of thyroid diseases, HIV, and diabetes on bone health, and the development of new treatments for the long-term management of osteoporosis. She also recently published a landmark trial on denosumab cessation. Sophie Sølling graduated from medical school also at Aarhus University in 2013, and she is doing her clinical training at current in internal medicine at Randers Regional Hospital. Sophie undertook a PhD in the long-term management of osteoporosis, which she just handed in last November. And today's session will be moderated by Dr. Elena Tsurdi from Dresden University, Germany. She's an author of 2 position papers on denosumab cessation. And she will moderate this session together with Dr. Sabs Ramchand from Harvard University, USA. And she recently completed a study evaluating the effects of denosumab cessation after combination therapy with both teriparatide and denosumab. So please enjoy the session. At the end of the presentation, there will be around 15-20 minutes time for question and answers. So please don't hesitate to ask your questions by using this Q&A tool. So please not use the chat but this Q&A function tool. And then we will now start. Thank you.
Thank you very much. And Sophie and I, we're very grateful for this opportunity to discuss discontinuation of denosumab. We've been looking forward to it, and we hope that lots of you will engage in the discussion after our presentation. We will do a bit of the presentation each and take you through some cases and some of the results and also our own study before we start the discussion. So here's your disclosures. First, I thought I would just remind everybody of the beneficial effects of long-term treatment with denosumab. This is a summary slide that takes advantage of the virtual twin model, where you can model what would have happened to the placebo group if that had been continued for 10 years. So here you see, starting from the left-hand side, from the left-hand side of the slide, you can see the exposure-adjusted subject incidence of clinical, major osteoporotic, vertebral, non-vertebral, and hip fractures in the gray columns in the placebo group and in the blue columns in the denosumab-treated women. So you can see substantial reductions in the number of all of these fracture types, including hip fractures. On the right-hand side of the slide, you can see the number of AFFs and ONJs would have happened over these 10 years in the denosumab-treated women. So if we treat women at risk of fractures, there is a clear positive benefit-risk ratio for our patients. But there will be patients that, for one reason or another, need to discontinue denosumab. And these are the early data. So we've known already from the phase 2 trials. This is the DEFENSE study. where women were treated for 2 years with denosumab, and the treatment was then discontinued, where you can see how the BMD increase built up during the treatment at the spine and hip disappears within the first year after discontinuation of the treatment. And at the hip, BMD even falls below the baseline level. And we know that that is because when you stop denosumab, there is an increase, a very rapid and prominent increase in bone resorption, here measured by CTX. And you can appreciate how the increase overshoots the baseline level. It seems to be self-limiting, as limited as you can see in the slide. It returns to baseline in 2 years' time. So this was after a short duration of denosumab treatment. In this slide, you can see from an extension of the phase 2 trial that even if you treat women for 8 years or 4 years, you see the same very rapid decline in BMD when you discontinue treatment, both at the spine and at the hip. In the FREEDOM study, there were women discontinuing either placebo treatment or active treatment with denosumab. And if we look at all the women in the study, irrespective of whether they had fractures before entering into the trial or not, you can see that if you discontinue placebo, your risk of fracture will remain the same, whether you're on treatment or whether you discontinue placebo. You can see if you are treated with denosumab, you have a very low risk of fractures, and that goes up to the placebo level when you stop denosumab. But what was also seen in this study was that there was some women, of course, experienced multiple vertebral fracture, and that risk seems to be higher in the women discontinuing denosumab compared to the women discontinuing placebo. If you just look at women who are at higher risk of vertebral fractures, namely the women who entered the study with an existing vertebral fracture, you can see that the absolute numbers are higher, but the pattern is still the same. There seems to be a higher risk of multiple vertebral fractures in women discontinuing DMAP compared to women discontinuing placebo. This has also been investigated in a real life situation. This is from an Israeli healthcare database, where they compared patients discontinuing DMAP with patients continuing DMAP. The study design is a little bit complicated, and I won't go into details, but just show you here that what they found actually was an increased incidence rate ratio for all the fractures they looked at, major osteoporotic fractures, all symptomatic vertebral and multiple vertebral, hip, and so on. A caveat for this study is that the observation time was quite short, but that was actually also the case in the discontinuation part of the FREEDOM trial. In this study, they show no effect on the fracture risk of history of vertebral fractures or prior bisphosphonate treatment. So there's been a number of case reports out there reporting that this is also what we see in real life. This is just one example of 24 postmenopausal women who suffered a total of 112 vertebral fractures. So quite a significant phenotype in the patients who experience this. So quite early on, and that means in 2016 and 17, people start wondering what to do about it. And this is the first report of an attempt to try to prevent this rapid bone loss seen after discontinuation of denosumab. It's a case series of 6 postmenopausal women who were enrolled in the FREEDOM trial in the placebo arm. So they received denosumab for 7 years, and when denosumab was discontinued, they were treated with 1 infusion of Zoledronate. And as you can see, that 1 infusion of Zoledronate was not able to prevent bone loss, neither at the spine, nor especially not at the hip. So that was the data that was out there when we started looking into this. And Sophie will now present 2 cases that illustrates what you can see in the clinic.
Right, so thank you, Bente. And our first case is a patient from the FREEDOM trial. Our patient is a 67-year-old postmenopausal woman with 2 vertebral fractures. She was enrolled in the Freedom trial in 2014 and received her last injection of denosumab in May 2014 after 10 years of treatment with denosumab. And during this period, her BMD increased by 9% at the spine and 11% at the hip. And on the left-hand side of the screen, you can see her biochemistry from the Freedom trial. And if you look at the top line, you can see her calcium levels. And you can see that it actually increases above the reference range during the last few years of the study. So her last injection of denosumab was in May 2014. And in November 2014, she went to her GP for a routine checkup. And you can see that the GP measured a low PTH and also a decreasing kidney function, which was actually normal a few months prior to this time point. And in December, you can see that the GP measured a ionized calcium, which was highly elevated above the reference range. So in January 2015, the GP initiated Zoledronate and referred the patient to our department for further investigations. And in April, you can see we measured bone turnover markers, and as shown in the table, both CTX and P1NP and also alkaline phosphatase was highly elevated above the postmenopausal reference range. And in the month following, you can see that her calcium levels slowly decreased and PTH increased and her kidney function normalized. So obviously the patient was extensively examined for the cause of her hypocalcemia, and it was thought to be related to her long-term treatment with denosumab, and obviously also the fact that she discontinued denosumab. And our second case is a case from the clinic. It's a 79-year-old postmenopausal woman diagnosed with osteoporosis in 2012. At that time, she had a T-score of minus 4.0 at the spine and minus 3.6 at the hip. And she initiated treatment with denosumab in 2012. On the left-hand side, you can see her BMD at the spine and total hip from 2012 to 2018. You can see that it increases at both spine and total hip. So she then became increasingly worried about the risk of adverse events, especially the risk of osteonecrosis of the jaw. So she was referred to our department in November 2018. And at that time, she complained about fatigue and hot flashes in the weeks following denosumab. We, however, found the symptoms to be mild, and since we at that time did not know how to discontinue treatment, she accepted to continue treatment with denosumab. She was referred to our department again in January 2020 with more complaints. At that time, she had muscle and joint pain, dryness of the skin and eyes. And we at that time had more information about how to discontinue denosumab. So she was offered a treatment with Zoledronate, but was not willing to try this treatment. So she accepted Zoledronate treatment. So her last injection of denosumab was in June 2019, and then she initiated Zoledronate in January 2020. So here we have her bone turnover markers. So she initiated Zoledronate in January 2020, and you can see that despite of treatment, her bone turnover markers increases rapidly, and CTX actually increased above the premenopausal reference range. And here you have her BMD, and you can see that after she discontinued treatment with denosumab, it decreases both at the spine and hip. Because of the changes described in BMD and her bone turnover markers, she was actually offered treatment with Zoledronate in September 2020.
Thank you. So that's clearly a case of a woman who's been treated for a long term with denosumab and where Zoledronate is not able to prevent the increase in CTX. So let's have a look at other studies that investigated discontinuation of denosumab. So we'll take them a little bit in the order of how long duration with denosumab was given. And so this is the DAP study that was actually done many years ago before we started thinking about this problem. But this was a patient's preference study. So the women were randomized to either Zoledronate for 1 year and then DMAP for the 2nd year, or the reverse order of the treatments. As you can see here in the bottom part of the slide, if you start with DMAP, you see prominent increases in bone mineral density at the spine, and you're able to maintain that in year 2 with Zoledronate. You also see very fine increases the opposite way around. But you can also appreciate at the hip, again, very nice increases with DMAP that is almost maintained with Zoledronate in year 2. So then let's look at the Greek study, which enrolled 57 postmenopausal women, 65 years of age on average, with osteopenia. They've been treated with denosumab for 2 years, and normally you would probably not consider discontinuing these women, but the situation in Greece is that you cannot get denosumab reimbursed once you have T-scores above -2.5. So that was the reason for this study. So they randomized the women either to 1 infusion of SOL or to 2 additional injections of DMAP. And here you can see that both treatments were able to maintain the suppression of CTX during the year of treatment, and CTX remained suppressed in the women who had been treated with 1 infusion of SOL, where it increases rapidly in the ones that discontinue denosumab. You can also see that with both treatments, there's a small increase in BMD over the 1st year, because these women had only been treated for a short period of time with denosumab. But you can also appreciate that BMD increase is lost when you discontinue denosumab, both at the spine and at the hip. This is another study where they looked at, it's just an observational study of 22 postmenopausal women in the early 60s who'd been treated for 2.5 years with denosumab. As you can see in the blue columns, quite prominent increases in BMD, but then they are treated after the 2.5 years with 1 infusion of SOL, and then BMD is measured again 2.5 years later. And you can see BMD is lost at all sites measured. This is another observational study from Switzerland, where they included all their patients in the clinic that had been treated with denosumab. And you can see they were in the mid-60s, and they had osteopenic BMD when they stopped denosumab treatment. What I think is really interesting in this study is that the women were treated for a varying period of time with denosumab to reach osteopenia, and then they were treated with 1 infusion of SOL thereafter. So that means that the time between DEXA 1 and DEXA 2 could vary between 2 and 5, but most interestingly, perhaps also the time between DEXA 2 and DEXA 3 varied quite significantly between these patients, because it was an observational study. You can appreciate that BMD is lost in all of these patients, despite 1 infusion of SOL. But interestingly, as I said, here you can see how the interval between DEXA 2 and DEXA 3 was in these patients, and you can see quite variable. And therefore, they were able to look at what happened between up to DEXA 3. And here you can see that there was absolutely no difference at the time of DEXA 3, depending on how short or long the duration was between DEXA 2 and DEXA 3. So to me, that's an indication that whatever loss of BMD there is, that happens quite early on, since we don't see a difference between the patients that had the DEXA at different time points. So now Sophie will talk about our study, and just remember that the only data that was available at the time when we designed our study was actually the Ian Reid data from the 6 women who discontinued from the Freedom study.
Yeah, right. So We wanted to investigate if treatment with Zoledronate could prevent increased bone turnover and bone loss in patients previously treated with Denosumab, and also if there was a difference in the outcome when Sol was administered 6 or 9 months after the last injection of Denosumab, or when bone turnover was increased. Our primary endpoint was change in lumbar spine BMD from baseline to 6 months after the first Zoledronate treatment. And we have a few additional secondary endpoints: change in BMD to other time points, HRP-UCT measurements, change in bone turnover markers, and also the proportion of patients who failed to maintain BMD. I will not be presenting HRP-UCT measurements today. So we included postmenopausal women and men above 50 treated with Denosumab for more than 2 years, and excluded patients with low energy vertebral fracture at any time, hip fracture within 12 months, osteoporosis, Zoledronate treatment for more than 3 years prior to Denosumab, and then a few additional points listed below. So the study design. At baseline, we randomized the patients to one of 3 groups: 6 months group, 9 months group, or observational group. Baseline was 6 months after the last injection of Denosumab. So the 6 months group was treated with Zoledronate at baseline. The 9-month group was treated at month 3, which is then 9 months after the last injection of Denosumab. However, we measured CTX monthly in this group, and if it increased above 1.26, which is 50% above the normal reference range for premenopausal women or men, or they suffered a low energy vertebral fracture or hip fracture, we treated at that time point. In the observational group, we measured CTX monthly and did a DEXA scan at month 3. If CTX increased above 1.26, BMD decreased more than 5% at month 3, or they suffered a low energy vertebral or hip fracture, we treated at that time point. However, they were treated no later than month 6, which is then a year after the last injection of Denosumab. So after the first injection of Denosumab, infusion of Zoledronate, we followed the patient for 2 years, and we re-administered Zoledronate if CTX increased above 1.26 or BMD decreased more than 5% at any site.
Oh, sorry.
So this is just to remind you that our primary endpoint was 6 months after the first Zoledronate, and our secondary endpoints were 2 and 1 year after the first treatment. So the primary endpoints are different, time points are different in the 3 groups. So we included 61 participants, and it's mainly postmenopausal women, as you can see in this table, with a mean age of 67. Most of them had a prior fracture, and the majority had been treated with Zoledronate prior to Denosumab. But it was only for a very short period of time, as you can see in this table. The mean treatment with Denosumab was 4.6 years, and they had osteopenia at both spine and hip, according to protocol. Unfortunately, we don't have DEXA prior to Denosumab treatment, but as you might recall from the Freedom trial, 5 years of treatment with Denosumab increased BMD at the spine by 14%, at hip by 7%. So we treated the 6-month group with Zoledronate at baseline. And in the 9-month group, we treated 18 patients at month 3 and 2 patients prior to that time point, since they fulfilled the CTX criteria. In the observational group, we treated half of the patients at month 6 and the other half prior to that time point due to either CTX or BMD criteria. We then retreated 10 patients 6 months after the first Zoledronate treatment, and 10 patients 12 months after the first Zoledronate treatment, and 9 patients 2 years after the first Zoledronate treatment. As you can see on these figures, we mainly retreated patients based on BMD criteria, and we mainly retreated patients from the 6-month group. So as for results, here we have a change in lumbar spine BMD, and we've shown the 6-month group. And you can see that despite Absol treatment at baseline, there's a decrease in BMD. And here you have the 9-month group, and you see a rapid decrease in BMD before SOL treatment, and which is then slowed down. And a very similar pattern in the observational group with a very rapid decrease in BMD before SOL treatment. And here we have all 3 groups together. There were no differences between groups 6, 12, and 14 months after Zoledronate treatment. And this is a change in total hip BMD, and similar to the spine, there were no differences between groups 6, 12, and 14 months after the first Zoledronate treatment. And here we've shown a change in CTX in the 6-month group, and you see that SOL treatment is actually able to suppress CTX in this group, but then there's a rapid increase to actually levels above the premenopausal reference range. And when you look at these slides, please remember that we actually retreated patients 6, 12, and 14 months after the first treatment with Zoledronate. And here we have the 9-month group, and you see a very rapid increase in CTX before SOL treatment. CTX is then suppressed and increases within the reference range. And a very similar pattern in the observational group, but please notice the very high CTX levels. And here you have all 3 groups together. There were no differences between groups 2 years after the first Zoledronate treatment. And here we have a change in P1 and P. It's a very similar pattern actually, but you only see levels above the reference range in the observational group. There were no differences between groups 2 years after the first treatment with Zoledronate. We also looked at interactions, and we found that a longer duration of therapy with Denosumab was associated with higher CTX levels at baseline, which is shown below, with treatment duration with Denosumab above the median in blue and below in red. And also we found greater bone loss in patients with baseline CTX above the median. And below we've shown change in total hip BMD from baseline to 2 years after SOL, with baseline CTX above the median in blue and below in red. So 62 patients experienced flu-like symptoms after Zoledronate treatment. We had no cases of atypical femur fracture or osteonecrosis of the jaw, but 6 patients suffered a fracture, 2 vertebral fractures and 4 non-vertebral fractures. And as you can see, it's patients from all 3 groups. So to conclude, in postmenopausal women and men discontinuing treatment with Denosumab after 4.6 years, a single infusion of Zoledronate given 6 or 9 months after the last injection of Denosumab, or when bone turnover was increased, was not sufficient to completely prevent an increase in bone loss and bone turnover. 2 years after the initial SOL treatment, the average bone loss at the spine was 4.2% and hip 3.8% without any differences between groups. We found that a longer duration of Denosumab treatment was associated with higher CTX levels at baseline, and also that longer duration of Denosumab treatment and higher baseline CTX levels were associated with greater likelihood of bone loss.
Thank you, and Sophie. We have, of course, as I said, also looked into other studies that have looked at that. And in this table, we've tried to put together some of the studies. As you can see, some of them are observational and some of them are randomized controlled trials. And in the second column, you can see the duration of Denosumab treatments in years. In the third column, you can see what were given subsequent to Denosumab treatment, and you can see all but the DAP study gave 1 infusion of Zoledronate, and we actually gave more than 1 in the Zoledronate study. And then you can see this the follow-up years, and then in the 2 final columns, you can see the change in BMD at the spine and at the hip between discontinuation of Denosumab and the next DEXA. And we put in a red line, and that's because we think there seemed to be a difference in the change in BMD in patients coming off a short-term denosumab treatment compared to women or patients coming off longer-term denosumab treatment. And as if it looks as if you've only been treated for a short period of time, you're able to stabilize BMD with either alendronate for 1 year or 1 infusion of Sol, where that seems not to be the case in patients who've been treated for a longer period of time. So we have some suggestions. First of all, it's important to remember that denosumab is a really good treatment. BMD continues to increase, which is not the case with long-term bisphosphonate, so that might be a benefit of denosumab. And the risk of vertebral fractures, non-vertebral fractures, and hip fractures are significantly reduced and remain to be so for up to 10 years. There are some risks associated with long-term treatment, AFF and ONJ, but the benefit-risk ratio is positive in patients with osteoporosis at increased risk of fractures. Discontinuation of DMAP results in rebound activation of bone resorption, bone loss, and perhaps increased risk of vertebral fractures. And I don't think we know the optimal transition from denosumab to bisphosphonate yet, and potentially treatment break or treatment pause is not clear, but depends on treatment length. Bisphosphonates will reduce, but cannot completely prevent the increase in bone turnover and BMD loss. So when you consider discontinuation of treatment, you should probably aim for a high enough BMD to allow for minor bone loss in these patients. And transition, which is something we haven't shown you any data on, but transition from DMAP to teriparatide is associated with very high bone turnover and temporary bone loss. So you might consider combination therapy in these patients. So together with one of the moderators today, I've been involved in an ECTS working group that put together a position paper that has been accepted in the Journal of Clinical Endocrinology and Metabolism, and is EPUB there if you want to read all the details. But we come up with some suggestions about how to manage the patient who stops denosumab in clinical practice. So first of all, as I said, expect bone loss, at least in patients on long-term treatment, and therefore aim for higher BMD before you consider discontinuation of DMAP. If the patient had only been treated for a short period of time, and in the paper we say up to 2 years, you could try alendronate for 1 to 2 years, but we again suggest monitoring the response with CTX or whatever markers you have available. And that's because we know not all patients respond very well to alendronate, and especially there can also be an issue with compliance. You can also right away give infusion with Zoledronate 6 months after the last DMAP injection. In patients who've been treated for longer term with DMAP, and we think that's more than 2 years, we think that the best evidence is for giving Zoledronate, and you should give it 6 months after the last DMAP. And we discussed that a lot, actually, and we realized that we don't have all the data we need, but we think it's a good idea to avoid the very prominent increases in CTX we saw in our study in the patients who waited an additional 3 months or even an additional 6 months before they were treated. So in an attempt to avoid that, we think it's important to give it at that time point. And we also saw in our study that some patients needed more than 1 infusion, and we therefore recommend monitoring the situation after the Zoledronate administration by CTX. And if CTX again increases above premenopausal reference range, you should probably repeat the infusion of Zoledronate. We also realized that there are some places where you're not able to monitor your patients with any bone turnover markers or CTX in particular. And one way of managing the patients in this situation could be to give 2 Zoledronate infusions with 6 months interval. And so so here is the headline of the paper, and also we give some additional recommendations about when to use DMAP. We think it's not generally a very good idea in young patients, because we don't see them getting treated throughout life. And but otherwise, this is summarizing what I've already stated. We also have some recommendations if patients experience vertebral fractures just after discontinuation of DMAP. So one option is, of course, to restart Denosumab treatment in these patients. We think you should probably avoid vertebroplasty or kyphoplasty in these patients. And also, it's probably not a good idea to give teriparatide as a monotherapy in these patients when bone turnover is still high. Could, of course, also treat them with IV Zoledronate or bisphosphonates. And if you want to give teriparatide, you should probably combine it with Denosumab. So thank you very much for your attention, and we're happy to engage in discussion and take any questions. Thank you.
Thank you very much, Dr. Langdahl and Dr. Sølling, for a very informative talk. I'd now like to open up for questions. Please send them to us in the Q&A panel, and we'll try our best to get through as many as we can. So we have the first question we have here is just related to the data that you presented for the Zolar study. And it asks, was the CTX adequately suppressed after the zoledronic acid to levels seen while on denosumab?
Would you like to answer that, Sophie?
Could you repeat the question, please?
Sure. So they're asking if when you were looking at your data for the Zolar study, when you used the zoledronic acid after denosumab, did you have suppression of CTX to the same level as you did with denosumab?
No, it was not suppressed in that range, and it was only in the 6-month group we saw a suppression of CTX after Zoledronate treatment.
And if I can add, I think that is spot on what we should do differently if we were to repeat this study, because, and that's why I highlighted that the only data we had available when we designed the study was actually the Ian Reid study. And the discussion when that was presented at the ECTS in I think it was 2017, was that people were thinking, wow, they gave Zoledronate too early. There was not enough bone remodeling going on to actually get enough Zoledronate attached to bone. So that's why we had the 9-month group where we decided just to wait a little longer and also go for the CTX. But I think, and we thought because of that study that we had to allow CTX or bone resorption activity to be really going on quite a lot. And that's why we decided on that relatively high or very high CTX. With the knowledge we have now, I think if you want to control this, you need to be much more aggressive and aim to maintain CTX within the premenopausal reference range. And that's why you should probably be more aggressive over the first 6 months and aim for that. But we need to show that in a study, of course.
Yeah.
Also, I think that we should. Sorry, I think that we should have lower CTX levels because it's really high, the one that we've used in the Zoledronate study.
You mean as a threshold for starting treatment or for giving a second dose? Yeah, and just following on from that, if I may add, so what do you think that your results mean for the theory that you need active remodeling sites in order for the zoledronic acid to be taken up and be effective? Because in the 9-month arm, it wasn't nearly as effective as when you started it up front.
So that's an excellent question, and I think, when you look at the data from the Freedom and Freedom Extension, you see how there's a little bit of a release of bone resorption when you're coming towards the time for the next injection. So on average, CTX in our patients was 0.22, which is suppressed, but it's not completely suppressed because we could actually suppress it further with infusion with this infusion of Sol in the 6-month group. So you do need, we know that from when we do bone scans and other things, that you do need some kind of activity for bisphosphonate to bind to bone. or attached to bone. But I think generally that it's enough activity 6 months after DMAP to actually get bisphosphonates to work. The problem is that the recruitment of new osteoclasts, or because of rank ligand, or because of fusion of existing osteoclast or whatever, the push is so hard that I think this situation is more similar to a cancer situation with very, very huge drive on resorption. So as one infusion of Zoledronate 5 milligrams is not enough in a cancer patient with hypocalcemia to really control, or most often it isn't. I think it's the same thing. You just need more bisphosphonate to control this situation of massive drive on bone resorption.
Thank you. We have a question from David Kaff, who asks, the alendronate used 9 months after the prior dose of denosumab didn't seem to be effective. But, and this goes again to what we were talking about now about the bone remodeling. What about using alendronate or any other therapy earlier than the 6-month time point prior to the last denosumab dose?
I think that's another excellent, it is excellent. There are, of course, issues or challenges with alendronate because not everybody takes it up equally well. And I think there will be patients where it's just not good enough, because our patient, the case we presented, she actually had very suppressed CTX when we started alendronate. But even if we started it when turnover was still suppressed, it was not able to control it. So again, you might get away if you gave it daily, or I still think you need a higher dose of bisphosphonate to control this situation compared to what you need for just controlling like normal bone remodeling. We would, of course, have loved to have an alendronate arm in our study, but since, as you saw, a lot of the patients had been treated with alendronate before, and the reason why they were on denosumab was because they couldn't tolerate oral alendronate. So it wasn't a possibility in our study, but I know other studies are ongoing where there are alendronate arms. So I guess we will see if it works, basically.
Thank you. We have a question again from David Karff. This is regarding the rates of the acute phase reaction that you saw. He wondered whether 62% incidence after zoledronic acid was quite high, and whether you might have used prophylactic therapy with acetaminophen or any other medications for your patients in the study.
So it is high. It's surprisingly high. And when I saw it, I thought, okay, that's because Sophie is such a very caring doctor. So she had really interrogated all of the patients if they've just had one symptom that could be related to acute phase reaction. But then I talked to other people because there's a study quite similar to ours being done by Serge Ferrari, and he has experienced exactly the same very frequent and also very severe acute phase reactions in these patients. And there are people suggesting that you might see worse acute phase reactions in patients with high bone turnover. So that was just an idea that was explained to me the other day. So we'll go back and have a look in our study to see if there's any relation between the level of CTX when you get Zoledronate, to see if the ones with high CTX are the ones that are most likely to experience acute phase reaction. But if there's anybody with other ideas about why we see this very high incidence, we would be happy to go and have a look in blood samples to see if we can find anything.
Yeah, that'll be really interesting. We have a question from Marcy Shafetz, who asks, can you comment on the transition from denosumab to romosozumab?
Yeah, I can comment on it. It's still very much unknown. As you may know, there's an extension of the phase 2 romosozumab study that has just been published with, I believe it's McClung as first author, where women who were treated for 2 years with romosozumab, 1 year with DMAP, and then with romosozumab for the 4th year. And what you see there is when you look at the bone turnover markers, you see again this rebound activation of CTX. So romosozumab is not able to completely prevent that. It's probably blunted somehow, but still it's only 1 year of DMAP. So maybe it wouldn't have been that high anyway. And you don't really see an increase in BMD, but you see a stabilizing of BMD during that 4th year. So it can be done. You won't see big increases in BMD as you would do in treatment naive or even in bisphosphonate treated women changing to romosozumab.
Okay, and this question is about trabecular and cortical microstructure and whether you've investigated the effects of denosumab discontinuation on those parameters. And this question is from Arasha Panihifa.
We certainly did. And Sophie, you can explain more about that.
Yeah, we have. We measured, we did a HRP-CT scan at the distal radius and tibia at baseline and 12 months after Zoledronate treatment. And we've not shown the results here today, but basically it shows very high bone turnover at both trabecular and cortical sites. And
yeah, we see a thinning. We see a thinning of the cortex, which is probably due to endocortical high turnover and resorption. And we also see, which is, we're not really sure how to explain that, but we see a thinning of trabecular and a narrowing of trabecular space. And we think it could potentially be explained by trabecular tunneling, as is a phenomenon that has been seen in patients with very high turnover, like thyrotoxicosis, hypothyroidism, and especially if you treat patients with hypoparathyroidism and try to normalize their bone turnover. So because usually you see this thickening of trabecular with denosumab treatment. So it's quite striking how they get thinner, so markedly thinner. So yeah, but you know, ideally we would need bone biopsies to investigate that, and we don't have it, but so it's just a suggestion.
Yeah, thank you. In the Zoledronate study, why was BMD loss the primary indication for intervention in the observational arm rather than CTX? This question is from Michelle McDonald.
So in the observational group, we measured CTX monthly, and if CTX increased above 1.26, we treated at that time point, but we also did a DEXA at month 3, and if BMD decreased at that time point, we treated with Zoledronate. But after the initial Zoledronate treatment, we also measured CTX, and if it increased above 1.26 at any time in all 3 groups, we retreated. But we only retreated based on BMD criteria, actually, and also only at 6, 12, and 14 months, sorry, 24 months after the initial Zoledronate treatment.
Thank you. I might pass it on to Eleanor to continue on with the questions.
Thank you, Sabs. Yes, we have a lot of questions, a very vivid discussion here. We'll try to get as many as possible. I think maybe we can also stay on a bit, 5 minutes or so, in order to answer as many as possible. So we have a question from Dr. Michael Bolognese. So he's asking about the time point when one should decide to then switch from denosumab to another agent. So when would you consider that the patient is low risk enough so as to do the switch from denosumab to Zol or another agent?
Yeah, so my take on that would be that I would prefer, and that's the local instruction now in our department, that BMD T-scores needs to be above -1.5. If it's not because of an adverse event or anything else that you would like to discontinue DMAP. But we aim for a T-score better than -1.5. And that is because although we have a more strict CTX criteria now in the clinic for retreatment, I think it's not likely that you can go through this regimen without experience bone loss, at least in patients who've been treated for quite some years with denosumab. So just to aim for minus 2.5, and then many of the patients would be in the osteoporosis range again, and you would have to consider new treatment. So I think for this to be meaningful and to ask, because there is quite a lot of additional effort from the patient side to go through this first year. But just to make a comment also, maybe you pay attention to in the clinical trial that most of the drama is in the first year. We are in quite smooth waters in year 2. There are a few that get treatments due to BMD, but all the drama is in the first year. But the patients have to come for frequent measurements of bone turnover or frequent infusions. So I think when we want to stop, we need to be sure that we do not have to restart treatment right away again. So I would aim for minus 1.5 or above that.
Okay, very important point. We have another question from Dr. Oliver Bock. So he asks about the reference values of bone turnover markers, or in particular CTX. And it was this in your study based on premenopausal reference values, or if you use the Sheffield algorithm, so the Richard Eastel recommendations for CTX.
Sophie, you want to cover?
Yeah. We used our CTX cutoff level was 50% above the normal reference range for premenopausal women.
No, it was actually for postmenopausal women and elderly men. So that's why it's so high, because in our lab, the reference range for elderly men and postmenopausal women was all the way to 0.8. So the 1.26 is 50% above that, which is clearly too high. Yeah.
Okay. Another question from Dr. Bolognese, if there's any rationale to use denosumab 2 years and then another anti-resorptive, and then to repeat cycles of 2 years of denosumab, so to intervene with another anti-resorptive.
That's an interesting question. I'm not sure I can see the rationale for doing that, because I think denosumab is a really good drug. It's the best anti-resorptive we have if we want to increase BMD, especially at the hip site. And so, and we know it's safe with a positive benefit risk ratio for up to 10 years based on the FREEDOM trial. So for me, I would, if I started a patient on denosumab, I would do that either because she or he is at high risk of fracture or has really low BMD. So I would continue on denosumab until I have reached what for me would be a target. That would be no fractures for 5 years and a BMD T-score above minus 1.5. And then, depending on the age and other things in that specific patient, if she would, for example, was still only 65, I would consider trying to treat her with Zoledronate for 1 or 2 years and then have her on a treatment break. But if she's 85 or 90, I would just continue. I wouldn't stop, because it's too much of a hassle and the risk is still low for adverse events.
Yeah. We have another question from Dr. Marcy Scheifitz. So she's asking about indefinite treatment with denosumab, into which circumstances one would do that, and what about potential risks of this approach?
Yeah, indefinite is like really a strong word, but I think there are many elderly patients, maybe more fragile patients that live in care homes, or where I would just continue treatment, because if the indication is right and they still are at high risk of fracture, either because they've suffered fractures already or because of very low BMD, I would just continue, because it is safe, and maybe only if the patient is, so the risk of AFFs with long-term treatment seems, at least with bisphosphonates, to be significantly higher if you're Asian descent. But for most other races, it remains really low compared to the fracture prevention you see. So in elderly patients, I would be most keen to continue treatment. But as I said, if it's a 65-year woman who had like a vertebral fracture maybe 10 years ago and now has excellent BMD, I would probably continue, or I would probably consider discontinuing using this transition.
Okay. Another question which we have is from Dr. Fabrizio Pin. So he mentions the interplay between muscle and bone, and saying that denosumab, there is some evidence that denosumab also can ameliorate muscle mass and weakness. And do we have any data showing change in muscle function during denosumab discontinuation, or then add-on treatment with bisphosphonates?
Well, that is a very good question, and we did not measure anything related to muscle or muscle function in our study. And I'm actually not. I don't think I've seen any data on this topic. I don't know. You have all also looked at the studies and been involved in doing the studies yourself. So maybe some of you in the panel have some ideas about that, but I haven't seen any data on it.
No clinical data, and I think it would make sense to look into it.
Yeah. Yeah, no, it's good. It's an excellent point for anyone who's considering doing a trial on discontinuation of DMAP to look into muscle functions as well, and maybe even some biochemical markers of muscle function to see what happens actually. So that's an excellent idea.
Yeah. Another question of Dr. Deep, it pertains the aggressive root resorption following discontinuation of denosumab. So not dental sequelae like ONJ, but aggressive root resorption. And she wants to ask if in your study, what kind of dental sequelae you saw in these patients.
That's your question, Sophie. I don't know.
Yeah, no, we haven't collected any information about dental changes, no.
But we have no information about patients losing their teeth or anything, did we?
No patients, no. But we've not asked like at every visit, but we have no information about the teeth or losing teeth or something like that, no.
Okay, yeah. Yeah, we have a question by Michelle McDonald. She's of course very interested in rankle, and she asks if serum rankle levels have been measured in denosumab withdrawal patients. Yeah, and yeah, she says that Sol may not reduce this and therefore may not impact muscle function, just reduce bone loss. My experience is that it's quite difficult to measure rankle in humans in serum. I don't know what your take is on this, Bente.
That's exactly the same. So, so the short answer is no, we did not measure it. But of course, others have tried, and most who have tried have found very high levels of rank ligand in patients who discontinued denosumab, which is not a surprise, basically. But there are also problems with these assays because, yeah, they're big problems. So we haven't measured it. But it's really it is a great point because rank ligand may have other functions, as we discussed on muscles, and of course we will not probably do anything about that with bisphosphonate.
Okay, we have an interesting note from Dr. Stad because of the question before. He says the French group has looked into muscle mass and freedom, placebo versus denosumab over 3 years using DEXA, and did not find a difference in muscle mass between groups. So,
okay,
yeah.
Thank you, Robert. We'll have to look that paper up. Yeah.
Yeah. Okay, then maybe a clinical question. Dr. Bogdanu asks, what would you suggest to a premenopausal woman with low BMD of idiopathic origin, so Z-score of -3.2 and no fractures until now? Would this be a patient for denosumab, for other anti-resorptive, or watch and wait, or another anabolic treatment? So,
well,
scenario.
Yeah. Of course, it depends a bit on her age, actually, because if she's really close to menopause, you might make a different choice because you know she will start losing bone again right away when she goes into menopause. But generally, we have no data that supports treating premenopausal women without fractures with any osteoporosis treatments. So I would definitely do a very thorough investigation, which I'm sure that this doctor also have done, because most of these women with this low BMD, they either have undetected osteogenesis imperfecta or other underlying conditions, eating disorders, or it's very or they are small, and therefore BMD is smaller than T-score is low just because of the way DEXA is measured in smaller people. So I would be reluctant, especially I would probably measure like bone turnover, and if that was very high, again, I would look for a reason for why it's very high. But most of the cases I would not treat. In the clinic, I only treat premenopausal women with vertebral fractures or hip fractures. And then I tend to go for bone anabolic treatment if this is the case.
Okay. We have another question from Michelle McDonald. It has to do with P1NP. And since it does not appear to overshoot like CTX does during rebound, if you think from a pathophysiological point of view that in younger patients or in patients with higher pre-treatment BMD, the P1NP rebound, does it rebound higher as they're more able to mount a bone anabolic response to protect them during withdrawal? That's an interesting thought. So that if younger patients or patients with higher pre-treatment BMD, does the P1NP rebound higher as they're more able to mount a bone anabolic response to protect them during withdrawal? That the younger patients then would have a more mild withdrawal because of a milder overshoot of P1NP. I'm not sure this has been studied.
No, but I see where she's coming from, and it's an interesting thought, basically, and maybe it's something that Michelle actually could test in her animal models, because not all these animals had exactly the same BMD as far as I recall. In fact, what we saw in our study, and as Anne-Sophie mentioned, we do not have pre-DMAP BMDs, so we cannot exactly answer that question. But we saw that the bone loss was bigger in the younger women, in the younger patients. So it's not like young patients are protected, but so we have more maybe interpreted that as if their drive on turnover might be higher because most of our patients were women, so they were closer to menopause, but we don't exactly know why it is. We just saw the association with younger aged and more prominent bone loss in this study.
Okay, this is an interesting observation.
Yeah, so the young people are not protected. It is like I don't know if the mechanostat is more sensitive in younger people, maybe then, I don't know. It's just pure speculation. We don't have a good explanation. We just saw that bone loss was bigger in the younger. It could have been because they responded even better to denosumab, but that was not the case in Freedom. But since we don't have the pre-DMAP DEXA, we cannot say if it's just returning towards baseline and the distance between baseline is bigger in the younger patients. We don't know that actually, but there was a relation, so that the younger patients lost more bone than the older ones.
Okay. Thank you, Bente and Sophie. It has been a pleasure to have this presentation and also the discussion. You saw how many questions, and we still have many more questions, which unfortunately in real time we cannot answer, but I'm sure if there are burning points, I'm sure that Dr. Sølling and Professor Langdahl would be willing also to answer in an individual basis. And yeah, I will throw it back to Lisbeth to say the closing words.
Yeah, thank you. And well, you said it already, but I also would like to thank everyone for this, well, outstanding session, I think. And especially the speakers with their excellent presentations, touching on all the various difficulties and all the, well, together with these questions, all the things we may encounter and we should think about. I think it was a vivid discussion, and I would like to ask Lauren to put up the closing slides. I would like to.
In the meantime, can I just say that it has been a real pleasure to be here, and I think it's a great initiative, and I compliment you and ASBMR for taking this initiative. I think it's really great. We have enjoyed it very much. So thank you for having us.
Thank you so much.
Thank you so much.
Thank you.
And then I would like to show you all, we have our next clinical case workshop on February 16th, scheduled already. That's on the subject of glucocorticoid-induced osteoporosis. I think also a subject that all of us will be interested in, since it's also a problem for many, many patients, of course. And this will be presented by Dr. Kenneth Saag and Dr. Leslie Jackson from University of Alabama, USA. So please note this in your agenda, and see you on the 16th next time. And thank you all again for attending and all these questions. Bye-bye.
Thank you.
Bye-bye.
Bye.